We need to talk.
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 Artistic expression is truly a threat to the powers that be because it inspires creative thought.
We're all burying our kids right now. It's black male genocide. It's genocide.
I'm tired of funerals. I'm tired of balloon releases for birthdays.
There are black people who brought the current Moderna vaccine to us, to the world.
Community Voices starts now.
Hello and welcome to Community Voices. I'm Angela Poe Russell, coming to you from the Black Media Matter studio in downtown Seattle. Thanks so much for being with us. Today, our focus is all about urgent care for mental health. We all know that we desperately need it. The good news is that our options are expanding, particularly in King County. In the next hour, we're going to highlight the resources available, what's planned for the near future, and in many cases, it's free. Plus, how do you know if you or someone you love is in a crisis? And what does post-crisis care follow-up look like? And what about youth? We'll discuss the resources available to them now. Joining us for this discussion, some folks on the front lines of this work. Jennifer Winslow, Crisis Care Center's Planning Manager with King County. Thank you so much for being with us.
Thank you.
Yes, as well as Dr. Matt Goldman, Crisis Care Systems Medical Director, Amy Dodgion with Swedish Hospital, the Behavioral Health Acute Care, and Daniel Malone, Executive Director of Downtown Emergency Services Center. Did I get all the titles right?
Yeah.
Long titles, doing great work, big work. Thank you for being with us. I want to start just by level setting because, you know, words matter, especially when it comes to navigating medical care and mental health care. So how do you define a crisis? Maybe I'll start with you, Amy.
Crisis. Well, a crisis it can be very individual to the person experiencing it. So, I mean, I would say a crisis is anything that causes someone or a group of someone's or what have you, distress, you know, where you feel like you just don't really have control in a moment or with whatever's going on in your life. And you just don't quite have the capacity to use the tools you'd normally use to get through it or to, you know, make good, solid decisions.
Yeah. And Matt, what does that look like for a lot of people?
Yeah, I mean, it can show up in a lot of different ways. Sometimes it means somebody's, you know, kind of isolating themselves or secluding themselves, not interacting with the people in their lives the way they normally would. Sometimes it means they might be quite distraught and are really anxious or just feeling like, yeah, they're in some kind of distress. And sometimes it can be very visible where you can really see somebody look like they're suffering. So it can be all the way from suffering in silence to suffering quite visibly. And clearly everybody in any of those kind of situations.
Yeah, and Daniel, I see you nodding your head.
Yeah.
Were you going to add something there?
Well, I think about these things from the perspective of what we see in homelessness programs on the streets and crisis response programs in the community. And the more severe ones that we come across, I would characterize as somebody losing the ability to regulate themselves as they might normally do. They're having the worst time of their lives, often precipitated by something else, some external factor, and they are struggling with how to get through that, and they need some extra help.
Yeah. What about, I mean, does a person have to meet a certain medical threshold in order to get help or access to some of the resources that we have? Jennifer, I don't know if you want to speak to that piece of it, because I can imagine people, depending on how you're raised, thinking, okay, I can totally manage this. Mm-hmm. It's not that bad. Mm-hmm. Like, is there a certain medical threshold we should think about in terms of access?
You know, to piggyback on what Amy was saying, I think the basic way to describe what a crisis is when a person's stressors outweigh their resources.
Let's repeat that. Okay, when a person's stressors outweigh their resources.
Right. So to that point, a person gets to define what their crisis is because everyone's threshold is going to be different. So what I may believe to be a crisis Matt may not believe to be a crisis, and maybe it's because of my coping skills, my cultural background, my influences, things of that nature. And so to think about if a person's in crisis, they get to define that, and it's simply their stressors are outweighing their resources in that moment.
Oh, that's good. Is there a certain threshold that you have to meet, Matt, in order to get care or access some of the resources in King County?
No, the whole point of our system that we're building, our crisis system, is it's no wrong door. Anybody can access care wherever, whenever they need. And we really want to make sure that that idea of people get to define their own crisis, that means that the door's got to be open to you no matter how you're defining that crisis.
That felt like the hugest weight off of my shoulders, if that's the case, because I don't know how many of you all watching or those of you who have had to ever navigate certain things in our system and how it can feel like, oh, you need to go over there or call this person or do this. And it's like, I need help. Yeah. So you're saying no one's going to turn you away.
That's the point of the system we're building, is nobody should turn you away. You should be welcome to get help wherever you're looking for it in our crisis system in the county.
I love it. Okay. Let's talk about trends. Like I said at the beginning, you all are on the front lines of this. Daniel, what are some of the trends you're seeing in terms of behavioral health right now?
I think things are moving in a positive direction after having been in a really, really deep hole where, especially in the early years of the pandemic, there were more people struggling overall, across the whole population. And then when that kind of additional stress came on top of people who were already struggling with a lot of things, it expressed itself in a lot of really problematic ways. And so we were seeing in our various programs serving people with serious mental illness and substance use disorder, a set of behaviors that were just more sustained and intense than we had been experiencing before. And at the same time that was happening, we were turning to the broader system for more help than we ourselves could always manage to provide, and seeing that the system itself was overwhelmed. And so the big trend that I observed during this time was that we needed so much more for so many more people who were not doing as they needed to do. And so I'm super optimistic that things now are turning this corner where there are some more resources. And I think also, just some things have settled out a little bit due to the passage of time, but it's really the addition of the new resources that gives me the most optimism.
I love that. And we're going to talk about those new resources in just a few minutes, which I'm excited about. We're going to show a video. Amy, I just want to touch base with you because you work at a hospital, like you're very close up to emergency rooms. What are you seeing in terms of trends?
So I think, I can piggyback on some of Daniel's thoughts. We have seen an increase in acuity. I think, especially post-pandemic, the people that we're seeing are sicker, if you will, or having more, they're not necessarily coming to get the help or not knowing where to get the help when they need it in the moments that they need it. So by the time they finally do, it's worse. So we also see a lot of, we've seen an increase in workplace violence in our hospitals as well. Just because, we're getting a lot of people who come in who are really in, an acute state, just and combative, and they don't mean to be. It's just the space that they're in. But we've learned a lot of lessons, I guess, over the last few years in managing that better, which is good. But it's still pretty distressing. And in the emergency rooms, especially, we cannot say no to anyone. And I don't think that we should, but anyone who walks through the doors and you want to be seen will get cared for. And it doesn't matter why you're there, if it is considered urgent or emergent or not. And so with that comes a lot of responsibility for the hospital systems on what it is we can do for folks in those front lines. Like most people may not, let's say, go to an inpatient psychiatric facility, but they do come to ERs. And so we really touch a lot of the population. across everything. People come to the ERs and they have needs, and they're needs that we cannot serve. And like Daniel was saying, we're not set up to provide people with all the things they need when they're in crisis.
Right, which is why we have this new crisis care
Yes.
system that we're going to be highlighting.
Yes.
Before we get there, I just want to understand one thing. You said you've seen an increase in workplace violence, so people acting out at work.
So incidents happen of physical or verbal violence against our staff.
Oh, that kind of.
So
okay.
that's how that's what we call it in our work setting. That's what they call it in every work setting. But yes, it's patients coming in states that are difficult to manage, and we're getting hurt.
Okay, so this is a good time then to dive deeper into what's being done to help. 2 years ago, voters approved the Crisis Center Levy, basically a tax to fund 5 crisis care centers and create a treatment system in King County. Well, one of them is now open in Kirkland Connections. And earlier this year, then King County Executive Dow Constantine gave a behind-the-scenes tour of this new facility. Take a look.
There's a lot of progress being made on behavioral health all around King County. Today, we are at the Connections Crisis Center in Kirkland. It opened this summer, product of a partnership between our Northeast King County cities, and I really want to applaud them for taking the initiative to meet the needs of their residents.
We provide immediate access to mental health care for patients in the community that are currently experiencing various degrees of mental health crises. Our job is to provide immediate access to care, treat them with respect, an unbiased view as well, and make sure that they receive the best care possible.
In most acute care hospitals in the United States, if you have a mental health crisis or a psychiatric emergency, you'll be evaluated in the emergency room by an emergency physician or emergency PA. Those kind of providers really don't have any formal mental health training. They obviously see a lot of mental health crises, but they don't have any training in particular of how to manage it or how to deal with it. The alternative is coming to a place like this, which only sees mental health crises and psychiatric emergencies. They get evaluated by a psychiatric provider immediately from the get-go, allows us to start treatment right away, determine what level of care do they need right away.
We have 32 observation chairs, and we have 16 beds in our crisis stabilization unit. At any given time, we could have up to 64, 70 folks. I think we're offering a new level of care that provides communities the opportunity to have behavioral health emergency services provided right away.
So not only are our resources expanding, but our panel is too. We have someone new to the team here, Representative Nicole joining us here on the panel. Thanks so much for jumping in. And I wanted to add you to the conversation because it's my understanding you and Daniel were instrumental in reimagining what crisis care could look like. So tell me about your journey, why you were like, hey, we have to do this.
Yes, so I've been serving in the legislature for almost 10 years now, and I have been working on issues related to improving community mental health, substance use treatment. And I have a background actually working in community mental health and in homelessness services and housing. And I brought that to my work in the legislature. What we saw in the beginning of the pandemic, going back to 2020, was really a crisis in our ability to respond to people's needs, both, as you've heard, the acuity of people's conditions, so the level of hurt and despair people were experiencing, but also the growing number of people who were challenged. And that's not surprising. During the pandemic, it was very disruptive to many of our lives and our communities. And so many of us got together and really rang the alarm bells about it. So that was happening here in Seattle and King County. It was also happening at the state level in the state legislature. I was part of a group that went down to Arizona to look at how they had fashioned together a crisis response system that we did not have here in Washington. We learned a lot about that. We started making investments in more crisis stabilization centers around the state. But Seattle and King County really didn't have very much. There had been one long time crisis response center, but it was inadequate to the number of people in our region.
Gotcha. And Daniel, that's where I want to bring you into the conversation, because the Downtown Emergency Services Center had a crisis program, if you will, but clearly doing great work, but clearly more was needed.
Yeah, for sure. We had a program with a couple of different components. One was called Mobile Crisis Team that went out 24/7 anywhere in the county to try to assist somebody where they were. And then there was also a facility that some of those folks could come to for a very short period of time for more intensive psychiatric stabilization. And especially because it was during this time in the pandemic when we had to put in measures for more distancing and so forth, it reduced the capacity of the facility, which was inadequate to begin with. And so all these problems kind of compounded to make the overall situation a lot worse.
Yeah. Amy, what is the significance of this new development, having the one crisis care center open and knowing that more are coming? How would you describe the significance from your vantage point?
It's highly significant. I mean, I think that we are all just craving this something more to add to the continuum of care for behavioral health services in this county. And it's funny with the DESC, we've been referring people there forever, to their crisis diversion facility. And it's the only thing in town. It's it. And you've got all these hospitals or ERs, emergency rooms, doing the same thing, referring people, and they cannot manage the volume that we have that's needed. And it's like, it's a domino effect. One thing just falls on another, and it just becomes this huge nebulous problem, and it just, a problem begets a problem begets a problem. So the hospital systems are thrilled to know that we're going to add something to the continuum of care that is not us. So in the emergency room, we feel, and my staff feel, we're not set up for success with the people that we see, because we cannot offer them what they need in that moment most of the time, unless it is against their will, psychiatrically, because they're so decompensated from their mental illness or substance use disorder that they cannot function, or they want to harm themselves or other people. And so there are some situations where ERs and hospitals and my staff really can help folks, but it's very specific, right? And so people come to us because they don't have a place to stay. It's cold. They don't have access to basic needs and food and things like that. So why wouldn't you come to the place that's going to say, you can come here if you have something to come here for, So
and then there's also there's the follow-up and needing something more long-term than an overnight visit in the emergency room, right?
Right. And we do refer patients to different programs. Like, we're going to be there for you and assess you and care for you in your crisis, but we are going to put you in but work with you to find the right discharge plan. So that could be inpatient or outpatient or all kinds of things. But we also see a huge population of people who aren't necessarily in a psychiatric crisis, but they're in a basic needs crisis or some other kind of thing.
It could lead to a psychiatric crisis. I mean,
it could
absolutely.
It absolutely could. But the thing is going back to my earlier point, like, we're not set up for success in the emergency department. So a lot of times we're discharging people just to the street. So that does not feel good, because we know a lot of times things have to get worse in order for us to be able to intervene and do anything at all. So, essentially, first till, we're all just seeing people in the ER, and then, out there on the street. I mean, there are times I'll come to work and there are people laying on the sidewalk. And we're all like, if there could be something for some people to go to instead of us, yes, because they're here in downtown.
Yeah.
And they're not going anywhere. And, the hospital systems, the few crisis things we have now cannot manage the burden alone.
I love that when you say, like, if there could be, and now that's for the direction we're moving with these crisis care centers. So Jennifer, let me make sure I got this straight. So we have one crisis care center open. The plan is for 4 more. And anyone having, even if it's not to the point, like Amy said, a big psychiatric crisis, but any kind of mental health, like you think of urgent care for mental health, you can just go in there. You don't necessarily need your insurance card and you will get help.
Correct. I mean, you're doing this for me.
Well,
I don't say much, truthfully.
I mean, it
Right?
sounds like a no-brainer, but we haven't had it, right? In a comprehensive way.
Exactly. I think that's exactly what it is. We're talking about a behavioral health urgent care component, which is that walk-in, kind of that, I'm in crisis, I don't know what I need. You know, when we think about a crisis, we often think about intervention, and then we also think about postvention. But I like to think of that behavioral health urgent care component as almost helping with that prevention. Oftentimes we don't think about a crisis until it's completely at its at its cusp, you know, and the goal here with urgent care is that folks can recognize I have something going on. I may not know what I have going on, but I can go and I can get my needs met. And, you know, what we have found just from data is that about 80% of folks who will attend that behavioral health urgent care will actually get their needs met. That's not to say that's always how it's going to be, but I think that really drives home the point that that behavioral health urgent care component is a critical component that really speaks to what Amy is describing here in the hospitals in terms of the system. There's not enough space. And so how can we create an opportunity for folks to go get those needs met so that they don't find themselves in the hospital?
Yeah. And that, Dr. Goldman, what kinds of things can you do there? I mean, you're on the ground. What kinds of things can you do to help people if they go to this clinic?
Yeah, well, that's what makes a crisis care center so exciting as an alternative to emergency rooms is emergency rooms, I mean, like Amy was saying, they're really not set up to be able to help folks the right way. Crisis care centers are that specialized behavioral health center where they can offer a wide range of things that you might need. So you can, you know, first and foremost, connect with people who've lived experiences similar to your own. There's peer specialists who are based at these centers who there's a strong focus on just connecting with you, meeting you where you're at, figuring out what are your basic needs. Crisis care centers are not places where you come saying you've got basic needs that aren't being met, food, water, you know, clean clothes, and get turned away saying, no, we don't do that here. These have to be centers where they're understanding of those kind of needs and meet people where they're at. And so then once you've got somebody there in a way where you're really focused on engagement and connecting with them, that's where then you can open up a lot more about, okay, are there mental health kind of resources that you need? Do you need a referral to some kind of treatment? Do you need potentially medications or not, depending on what you're looking for? You know, what kind of follow-up aftercare do you need? It's really meant to kind of open it up in a way that's much more centered on the person and uses those kind of specialized behavioral health approaches to meet somebody's needs.
Yeah. So the one in Kirkland has been open for how long now? How long has it been?
Since
August.
August of 2024. Yeah, almost a year.
I was trying to count months. Let's not do that. Let's just
how's it going?
You know, I will say that it's going well, that it is a process. The big piece here is education and making sure that folks are aware that this resource is out there. And part of that also is education around what is a crisis. You know, I think what you were describing earlier, I'm in distress, but I don't know what I may need. Is that somewhere I can go? No, I should just stay and deal with it on my own. And so I think a huge part right now for us is really just around engagement and outreach and education. But what I will say is that first responders are using it and they speak very, very highly of the relationship that they have with Connections in Kirkland.
Yeah, it made me think about, because I'm sorry, were you going to say something?
I mean, I visited it when it first opened and it's great. I mean, this whole idea of no wrong door, and I'd want to say, like, we've talked for years about creating a system that people have a place to call, someone to talk to, and a place to go. And we've done a lot on the hotlines, on the 988 hotline, and on expanding mobile crisis. And this idea that you can even go to a place is such a new concept. So people are still getting accustomed to it, but it is so valuable. It's so valuable.
Yeah, so you want to touch on that because we've had the mobile crisis teams, and how are they working with this? And is it expanding? So who wants to talk about that piece of it? Mobile crisis teams.
I could jump in on that a little bit. So, you know, we really think of crisis services as a continuum. What do I mean by continuum? I mean, there's many different kind of levels and entry points, and really the goal is for somebody to be able to get care in the way that is as centered to their experience as possible. So the easiest way is picking up the phone, calling for help. And so that's where the crisis call lines come in.
Is that the 988?
That's 988. We've got a local regional crisis line in King County. We've got specialized lines for teens and other kind of...
And someone will come to your house.
Well, so if when you're talking on the phone, that crisis call taker, by talking to you says, you know what, I think that somebody could really benefit from having somebody come in person. That's where the mobile response comes in. So you get that mobile response to come see somebody, adults and kids. We've got teams for both. And the Crisis Care Center levy increases the capacity of both of those. We're increasing the number of teams, really trying to have enough of those responders available to meet anybody in the county when they need services in a timely manner. And so that's when you get that response in the community. And it's nice that it's in the community because I've been on mobile crisis teams myself. I've worked clinically. And there is nothing like getting to see somebody in their home environment for both the clinical team, but also for that person who's in that crisis, because it's so hard coming to the hospital and you're in fluorescent lights, uncomfortable environment. You want to avoid that. And so for somebody to be able to come to see you in your home environment just goes a long way. And so ideally, somebody can get their needs met that way. But if that's still not enough and somebody really needs to be in a safe environment in order to, feel safe and feel like they can continue, living and, thriving in their lives, that's then where that crisis facility can come into play. And so that mobile team can help somebody get there. They can offer a referral to the crisis facility. Or again, if somebody doesn't call and they decide, I'm just walking in, then the crisis facility can see those folks too.
Daniel, what do you see as the overall community impact of having this? I mean, you in emergency services, you're dealing with our most vulnerable residents, people experiencing homelessness, and then they also might have the co-occurring psychiatric distress or mental health. How do you see this overall impacting the community and your work?
There's been a real important shift in the mobile response capacity of the system just over the last 6 months or so, where we've actually had this ability to do that kind of in-person response countywide for more than a dozen years. The very high majority of those calls to the behavioral health crisis professionals came from law enforcement, where police were the ones to first get involved. 911 is the number everybody knows, and they don't know who else to call, and so they would call 911. And a lot of police officers are very highly skilled at interacting with people with behavioral health conditions because they have those interactions a lot. But they also recognize they're not necessarily the right people to be responding. And so they would make this kind of call, and that was a very helpful thing to do. And then the behavioral health system could get involved at that point. The big shift that's happened really at the beginning of this year was switching over to 988 as the main receiver of calls, where instead of the mobile crisis behavioral health response being essentially the second response, they could now become the first response. The community member calls 988 instead of 911. The 988 call taker recognizes there's not an imminent public safety threat going on here. There's not a law violation that requires a police response. And they can make a determination that we want to send an in-person response that is behavioral health instead of law enforcement and dispatch those folks. And that's what's been happening now. There's also been an expansion of the availability of that kind of service. So the organization I work for, DESE, provides that service for mostly the city of Seattle and a little bit outside. And another organization does other parts of King County. And it's really just shifting the overall experience of it, where the calls are much less law enforcement originated. There's still some of those, and we want to provide that service for sure, but the community now is starting to get involved more than they were before. And it was a very common question I would get over the years, that people would say, I see folks who clearly need help, and I don't want to call the police?
Mm-hmm.
What can I
Look,
do?
I was that person. I think, in my neighborhood, I want to say 3 times in the last 4 years, I've had to call 911 over something I could clearly see was someone in distress, but not knowing who to call and knowing there needed to be some intervention. So you're telling me, it sounds like for all these cases, because many times the 911 person will say, well, do you see a weapon? And I'm like, I don't really see a weapon, but there's clearly something going on here. It sounds like to me 988 is that response.
I think you can call 988, and if they assess that there is a need for law enforcement,
then
they can make that happen.
They can bring them in, absolutely. Okay, we still have so much to talk about. We're gonna have to take a short break first, but I wanna dive deeper into the crisis care centers, who's working at them, and also what post-care follow-up looks like, because we're talking about having 4 more centers in King County, but there's tension over where they should go. So we're going to talk about that, as well as resources for youth. So stay with us here on Community Voices.
I had some dental work done, and pain pills were introduced. It flipped a switch that I didn't see or know or understand. And I tried multiple times to show up and be a parent to those kids, but I couldn't do the minimum. And the grief about it was so huge that I would have to drink to deal with what it felt like to be in my body. Each one of those people along my journey has contributed to my success. Don't count us out. More people recover with support. Learn how you can help someone's recovery at supportaddictionrecovery.com.
Well, welcome back to Community Voices. I'm Angela Poe Russell, coming to you from the Black Media Matters studio in downtown Seattle. Joining our panel now is Paul Rosenthal, a community member of Seattle. Thank you for joining this conversation.
Pleasure to be here.
All right, we've been talking about the additional 4 crisis care centers that are planned for King County. 1 is in Kirkland already, but we have some others in the works. Jennifer, I'm going to come to you on this. We have 1 kind of being talked about for Seattle.
Correct. So just to clarify, there are 4 additional centers coming online. 3 of those we like to describe as regional crisis, with 1 being specifically dedicated to youth. That's that 4th one. And so if you think about it, 5 centers, 4 are regional crisis, 1 is the Youth Crisis Care Center.
I love that.
However, youth will be able to be seen in the behavioral health youth urgent care, or the behavioral health urgent care component of a crisis care center.
Okay, so even though there's 1 dedicated to youth, if their closest one is at a regional center, they could still go to that one. Okay,
Correct.
That's awesome. All right, so
Yes.
tell us about what you're hoping to put up in Seattle.
Correct. So we are currently looking at a potential site that is on Broadway, formerly known as the Polyclinic. And we have been in conversations, and we've been doing community engagement around this location. The reason why this location has been identified is just really to what Amy was describing around the location. It's prime location. It's centered within kind of 3 hospitals. It's already, zoned to be a medical facility, and it's really in the heart of the community. And so right now, the county is currently doing due diligence to assess if this is going to be a viable option. That included both from a capital development side, but now our efforts are really centered around community engagement and making sure that, we really want to see how community feels about this location for a center.
Right. And there has been some tension around where the center should go. Representative Macri, I'm sure you're used to tension in your role. What's your take on all of this in terms of the location?
Yeah, so I think everyone tends to like the idea when we have it, particularly around behavioral health care. Yes, we need more of it. We need more of it everywhere. And
I remember voting for it. I remember seeing this. I'm like, there's a levy for mental health care. Yes, I'm voting for that.
Right. But then when you pick the specific site, then I think people's questions become a lot more specific. And I think that's where we are right now with the community engagement that the county is doing. Those questions come up of where are people going to come from? Where are they going to go to when they leave? I think those are reasonable questions to be asked for community members to ask. And I think we as elected officials and government leaders have an obligation to have reasonable responses so people can understand. I've gone through a lot of community siting processes over the years. And what I find most of all is people want to understand, what is this going to look like? Like, talk to me a bit about day to day. What is it going to look like? I live down the block. I operate a business on the street, and how will my experience change? And I think that's what a lot of the conversation has been.
And that makes sense. I'm sure you can understand the concerns. When you mention small businesses, you think about going through the pandemic, and just many have not fully recovered from that. And then, dealing with perceptions of crime or the reality of crime or whatever in an area, and wondering, okay, is this going to bring more people? Is this going to cause more problems? I'm sure those are discussions you've likely already had in the community. Yeah.
Yeah.
Okay.
Well, those are conversations that we're currently having right now. When I'm just listening to the panel talk, and when we all describe the work that we do and how we all are so comfortable working in a crisis, we have to remember that not everyone is well versed and understands mental health and what a crisis looks like. And so while I think all of us run towards a crisis, the reality is most folks don't understand or just need a little more education around what that is. And so again, a lot of the community conversations right now are, what does this actually look like? I don't understand. How is this going to help? Because right now, we already have so many concerns around the safety of our community. We need to make sure that resources are to come in and enhance and not hurt.
Dr. Goldman, what would you say to people who do have those concerns, because you work directly with people?
Yeah, I mean, what I was talking about earlier around engagement, that engagement starts as soon as somebody walks through the front door. It does not end when somebody's about to walk out the door on their way out of a crisis care center. We know that a crisis might just be a short period of somebody's life, but the consequences of that crisis often tend to last for days or weeks or months, and that's much longer than somebody's going to spend at a crisis care center itself. And so from the moment that somebody's getting ready to leave that facility, there's a strong focus on things like transportation. How are you going to get to where you want to go? Just opening the door and somebody walking out the door, that's not necessarily what support looks like. Support is often much more about, how do we get you where you're trying to get? Does that mean that we get a ride for you? Does that mean that you need some other kind of transportation? So really wanting to make sure people are getting to where they're going to be most supported after that crisis, and then continuing to follow up with them and engage with them for that post-crisis follow-up kind of care.
So unlike the emergency room where, you could have an overnight stay and a referral, and then Amy, you talked about, then you have to let them go into the community. It sounds like here a longer stay could happen, and you actually connect them where they're supposed to go, right?
Yeah, exactly. We really want to avoid somebody having to discharge to the street, as it's often called. We really want somebody to be able to discharge into a supportive plan where they're going to be able to get their needs met.
That's awesome. Paul, you live a couple blocks from the proposed site. How are you feeling about this?
I love it, which is why I'm here. It's because I've been really vocal about the fact that everything that I've been learning about this potential place going up sounds like something that's really going to change the face of the neighborhood that I live in.
In a good way.
Yeah, in a very good way. Like as just a human being, I don't like seeing other people having to sleep outside and like seeing people suffering. I don't like having to deal with like all the needles on the street. There's like all these people that like walk their dogs like every day. There's tons of kids in my neighborhood. There's like a multi-level school or multi-grade school like right down the street. But I want everybody to feel like they can have like a good life, and seeing people like sleeping in the parks, that's not a good life. Like nobody should have to sleep in a park, especially when you can tell that they're having like a mental health crisis moment, right? And like I'm not a medical professional or anything, but I'm pretty versed, I think, at this point of knowing what a crisis looks like. When I see somebody like walking the street like screaming or smashing things, or the firebugs that we've had to deal with. There's all the folks who like go to the methadone clinic, and I see like a rotating like different group of people in like the decade that I've lived in that neighborhood. I would love to know that if something bad is happening to one of those folks, because this is like the plan that's been presented to me at the 2 pop-ups that I've gone to that like your team has put together. I could even just be like, hey, can I walk you over to this thing and help you to get like, like some care? I never see police officers helping people out unless like they show up with like their lights and their sirens going off. But I never see like anybody out there just being like, hey, like you've been in this park for like a week. What do you need? What can I do for you? And knowing about all the different like follow-up services, because I think you folks talked about like getting people like attached to like better mental health, like, care, that there's going to be potentially a bunch of beds in there for extended stay. And then like, like knowing that people can get like more like intensive like substance use disorder treatments. Talking to people like you has got me really well versed in like the language of it. Yeah, 'cause like I said, I don't work in a hospital setting or anything. I work in low income housing. Yeah.
You
I
sound
just wanna see
excited
all
and
of it.
hopeful
I
about
am.
this.
I'm super excited about it. I'm just sad it hasn't happened already.
Yeah. What's y'all's reaction to just listening to his experience?
Yeah,
Love it.
I love it. I have a lot of thoughts. Like from my perspective, one thing about the crisis centers that I have seen personally as a gap for so many years are the 23+ hour reclining chairs that people have, because sometimes a crisis can resolve itself just with some time. Yeah, sleep, rest. And, people don't necessarily want to be in the emergency room. Some folks wake up in the emergency room and they're like, how did I get here? I didn't necessarily want to be here. So I think having that a multi-tiered option in the crisis center and one where you can just go and be for 23+ hours. And hey, guess what? There's also mental health professionals there. There's also peers there. There's, I'm guessing, medical care there. It's really something, it's really great. And I think that just piece in and of itself, I mean, I know that the ERs, I know Swedish is very much looking forward to that piece of it. Because now we want to send people to Kirkland Connections, but transportation is a huge issue for us. That's a barrier. So having one just literally right down the street, I'm excited too. Let's find it.
Let's go. So she mentioned these reclining chairs. So I want to make sure we didn't lose that point. So tell us about this.
Yeah, so there's 3 components to a crisis care center, and I'll touch on the longer term stay as well. So the front door is the urgent care. That's where anybody can walk in and get that.
Anybody, whether they have money or not.
Importantly, thank you for mentioning that. So yeah, regardless of ability to pay, whether you have insurance or no insurance, nobody's going to come into a crisis care center and end up with a copay or a deductible. That's not part of this model. The county levy, the tax that was approved, is what's covering that gap.
Our tax dollars at work.
That's the idea. Trying to do right by the taxpayer. And so that's the idea, is that urgent care is that front door. People can come in. Jennifer mentioned this earlier. 80% or so of people who come into the urgent care, they're going to get their needs met in that setting and not need one of the other settings. But there are higher levels of care there. So there's that 23-hour observation, which is the recliner chair model, where somebody, it's a full psychiatric emergency service level of care. Any range of mental health, substance use related needs, that setting's going to be able to help you out. But it's a short stay, so it's a strong focus on, okay, we're making sure that you're safe, trying to focus on stabilization, but also where's the right place for you to continue to get those supports. And so, some people might need to go to an inpatient setting that would be outside of the crisis care center. Some people might be good to, be discharged to community care and get outpatient treatment. But there's going to be some folks who need longer in the crisis care center, who don't quite need outpatient, who don't quite need inpatient. They just need more support. And that's the third component of the crisis care center, which is the crisis stabilization unit, where somebody can stay for up to 14 days. There are 16 beds. They're beds, not chairs. And that's meant to be a supportive environment where somebody can have longer to do that problem solving and figure out, where should I be going from here? Again, talking to the peer specialists.
Or if there's medication.
Or if medications need to be adjusted, absolutely, that can happen in that setting as well.
There's that piece of it.
Yep.
We mentioned, I know Paul mentioned drugs. How did drugs, because we have treatment centers in the area, and I'm sure not enough. How does addiction interplay with mental health in this space, and how are you going to navigate that? Whoever would like to jump
What a
in.
complicated question.
I know, right? I was complicated asking
That's a good
it.
one, Angela.
It is. So I will start, and I definitely welcome the panel. So when I think about substance use, I think that is one variation of a crisis that a person may very well find themselves in. And so when we think about that front door, no wrong door, whether my crisis is related to perhaps depression or anxiety, or perhaps it is because of withdrawal or some sort of substance use, I will be able to kind of get my need met. When we think about the staffing model, folks have kind of touched on a little bit of who's going to be there. The staffing model will include peers, but also substance use professionals, as well as like licensed mental health professionals, behavioral health techs, and then also nursing staff. And so you have this comprehensive staffing model where there's a little bit of everyone that can lay eyes and say, okay, what does this person actually need? And so again, when we go back to what that crisis is, whether it is mental health or substance use, your needs can be met.
Does anyone else want to add to that?
I mean, I would just add, I 100% agree with everything you just said. I think the one thing to say is, having co-occurring mental health and substance use.
That was the word.
They're
Thank
both
you.
happening at the same time.
Correct, yeah.
That is, it's less the exception and more the rule. We just know how these things relate. Somebody's feeling really depressed and they might turn to substances. Somebody's using substances and then they're going to start feeling depressed. These things just feed off each other.
Yeah.
And so we really shouldn't consider themselves separate issues. It's all part of the same story. People are one person, right? And you got to, again, meet them where they're at, get them the services that they need. Strong focus on evidence-based treatments at these facilities too. So medication is a really important approach for supporting somebody with especially opioid use disorders. We all know about the fentanyl crisis. And so somebody who's using fentanyl, to be able to get off of that drug, medications for opioid use disorders, what we call them, are some of the most important and strongest evidence-based interventions that we can offer somebody. And so that's going to be available at these centers as well.
On that, I want to talk for a minute about politics, because politics, it definitely interacts with what we're able to do, and the reason I bring that up is because of cuts to Medicaid. I know we have our tax dollars from the levy, but are there any impacts to you all related to the Medicaid cuts? And I don't know if that's you, Representative Macri, or someone else.
Yeah, I think we're still assessing the federal bill that was just signed into law, the budget bill, what impacts that will have. There are choices that every state can make about how these cuts are actualized in our state. And so the governor and the budget writers, I'm one of the operating budget writers in the legislature, will be working on it, and the legislature itself will be making choices over the next year about how Medicaid will impact. There will be impacts to people and the care that folks are able to get. Just exactly what it'll look like, we're not sure yet. What it'll mean specifically for mental health and substance use is still unclear. But it is, it's a very unfortunate turn of events. I think our federal government stepping away from providing essential health care, especially to low-income folks across the country.
Can I just add, I'm just so appreciative of having Nicole in those spaces, in those conversations where we recognize that cuts are happening, and your point of, but the state gets kind of decide what that looks like. So having champions in those rooms to say, those cuts, this is how it impacts this population. Let's think about what that looks like. So just super appreciative. And I think it just highlights the importance of having legislation that is supportive of and having representatives that can kind of understand the crisis that is happening.
Yeah. And I mean, it sounds like, we want this program to be sustainable. We have the levy, we have these other centers planned. We know Seattle's in line. Are you able to share where the others are planned, or are those not on the map yet in terms of locations?
Yes and no, because they don't exist yet.
Right.
But the King County has been divided into regions. So there is the North Crisis Response Zone, which that's where Kirkland is currently. There is the Central, which includes, Seattle and Vashon Island. Then there's the East, and then there is South. And so those are kind of the 4 regional crisis areas. Again, because you live in a certain area, you are not restricted to your area. So let's say I live in the South End, but I've experienced a crisis in the North. I could still go to Kirkland. I don't have to just drive all the way back home. And then, of course, that youth crisis care center can be located in any of the 4 crisis response zones.
Okay. And Paul, what would you tell people, neighbors who are watching, if they are hesitant about these centers or the impacts? What would you want to be able to say?
I feel like the thing that I keep hearing the most from people is that if you put the center there, then homeless folks and drug addicts are gonna show up, and they're gonna cause mayhem in the neighborhood and everything. But the thing is, I've lived there for a decade. There are homeless people in our neighborhood already. There are tents in our neighborhoods already. This is the thing that could potentially relieve that for people. This is the kind of thing you deal with your substance use disorder. Maybe that helps you to actually find housing and keep housing. Maybe this is the thing that makes everybody safer. Right? Especially if right down the road, there's a place that somebody can go to who's obviously going through something pretty terrible, like right in front of you and the kids, you can make a simple phone call. It can be 988, or you could call 911 and say it's a mental health crisis. I don't need the cops. We need the medics to get over here instead, because we can do that as citizens. Like, that's a thing that like has been set up for us. Yeah, and these are the kind of things that they can make like everybody feel safer at the end of the day.
Okay.
Yeah.
Well said. Thank you for that. Okay, we still have a lot more coming up. We're going to talk about youth, post-care follow-up right here on Community Voices. Stay with us.
I was someone that the community gave up on. If I didn't have access to naloxone, I don't think I'd be sitting here today. Harm reduction services gave me all the tools and medications necessary to turn my life around. When we fully utilize these resources for needle exchanges, proper medical care, peer support, shelter, I, like many other people out there, we found a way to recover.
Find harm reduction resources at supportaddictionrecovery.com.
Welcome back to Community Voices. We've been having a great conversation on urgent care for mental health, specifically the new crisis centers that are planned for King County. You know, one thing I want to dive deeper into, and Dr. Goldman, I'm going to start with you, is around post-care follow-up, because you heard some of the concerns earlier. People like, what is this going to mean for our community, our neighborhood? So if a person is treated from at a crisis center, what options do they have from there?
Yeah, sure. So, there's going to be some folks who are coming into a crisis facility who are not at all connected to care. Some folks who might already be connected to care. Folks who are already connected might like who they're seeing and they might want to change. And so the whole point is about working with folks again to get an understanding of what are your care preferences. That's the first most important thing, because that's how you focus on engagement. If you're trying to tell somebody to go get some care that they don't want, they're not going to get that care.
Versus asking the question and having the buy-in.
You got to work with them. And so, but what the Crisis Care Center levy makes possible is expanding our toolbox of options that are then available to somebody. So right now we have outpatient programs, we have mental health and substance use services. There are options out there. But the really new piece of what the Crisis Care Center's levy is making possible is this post-crisis follow-up program.
Okay.
And so a post-crisis follow-up it's a team of folks. It includes peer specialists, it includes care coordinators, mental health clinicians, and then also access to medications if needed, where you've got that team to work with you after leaving the Crisis Care Center to kind of function as a bridge. We don't want anybody coming in and then feeling like they're leaving and they're kind of walking out like a bridge to nowhere.
Oh, how many of you have had this where they give you a paper with a list of people to call?
Yeah.
That's what we do.
I mean,
Exactly.
it's like, and then you call the people on the list and they're like, we can't help you.
And they're like, yes.
Or it's like, new
exactly.
phone, who dis?
Right.
But you actually are connecting.
That's the idea. So it's both the engagement and the navigation. These are complex systems, and people, when they're in a crisis, it's hard to process all this new information and to figure out where exactly should I be going here. There's even scientific studies that show that it's really hard to do that problem solving during a crisis.
Mm-hmm.
And so we gotta offer more supports in order for somebody to make that transition from that acute crisis into longer term
So
service.
stable when they leave.
Stable when they leave, and not expecting that somebody's perfectly stable the second that they leave, needing to continue to work with that person even after they leave.
Got it. Transportation, Jennifer.
Well, I want to just piggyback on that before we talk about transportation, is that discharge planning happens at the time of intake. And I think that that's an important piece to note. It's not waiting till you get all the way to the end to say, okay, what are we doing? But it's at that first touch, learning about that person, understanding who they are. Do they have natural supports? Can we lean into family? Can we lean into friends? Oh, you mentioned that you're connected in outpatient, but you didn't like that provider, right? And so it's really about getting discharge planning soon, so that perhaps at the end, one can say, oh, I already know, or, oh, I hadn't thought about that resource, and, or I don't know and I don't have resources. And so perhaps I do need to be connected with this post-crisis follow-up. And so it's a different avenue, but the importance is discharge planning happens at the time of intake.
Yeah. Anything else that is built into this that will make it successful for the community?
One thing that I just want to highlight is, it's important to manage expectations a little bit here, that a mental health facility is not going to solve homelessness. it's not going to solve poverty. It's not going to solve some of these major issues. It's part of a system. That's a system that's under strain, and there's a lot of challenges here to navigate for folks who are experiencing these things. And so the reason I highlight that is we put as much into this crisis care center thing as possible in order to support somebody while they're in that crisis and in the aftermath of a crisis. We even have it in there that some housing resources might be made available pending available funding. So if there's funds that are kind of left over to be able to do that, then that's possible. But we know that the housing problem needs to be getting solved with its own solutions at the same time that we're also working on the mental health crisis. And so just want to highlight that I think these things go in parallel and manage expectations a little bit, that this is not a silver bullet to solve all of society's ills. This is something that's really, again, meant to be that front door for people who have that mental health and substance use.
Yeah, and I could just see you nodding the whole time, like, yes, amen, and amen.
Yes, it's so true. Yep.
Yeah. And you're feeling, I mean, what I noticed when you were really nodding was just how all the post-care follow-up things that are in place. And it seems like you feel really good about this.
Yeah, I do. I think that it's, it's options, it's resources that people don't have, that we'll have now. And, realistically, is this going to solve all of our ill wills in our community? No. But it's going to where folks are who have these issues and providing services that have never existed before. And that is what is so exciting to, folks like me, folks that work in acute care, and all the hospitals in the area. Yeah,
Representative Macri, as you listen to all the plans for post-care follow-up, transportation piece, I mean, what's your reaction to hearing all that's in place?
I'm really excited about the post-care piece. I actually love how much thought has gone into all the elements of the crisis care center, everything from the urgent care to the that 23-hour observation you heard about, the 14-day, and then that post-care. And that we can count on that consistent approach in all regions of the county, which is something that we don't have now. So, I think we'll look back in a number of years when all of these are stood up and say, how did we ever manage without this? In thinking through all of these steps and all the things that we need, and what Dr. Goldman had said about, we need a lot of different things. I was part of some of those early conversations that resulted in the proposal for the crisis care levy. And it can feel overwhelming because we need to do a lot of things. We have a real housing crisis. We have a real challenge with people who are struggling long-term with substance use challenges. And we have a mental health crisis in our schools that our young people need help with. So there's many things we need to do. But when we came to it, we said, this is a thing that we don't have. And it reminded me of long ago, I'm old enough to remember before there was a 911 system, right? And you had to know, do we have the number to the hospital emergency room? Do we have the number to the police precinct? You had to know how to navigate this more complicated system. And then, community by community and across the nation, we opted for a more rational, consistent approach to get emergency care. And we left mental health care behind in that, and we're just catching up. So I'm really excited.
Yeah. You mentioned young people, and I want to take a few minutes to just talk about what we have now that's in place, because someone may be watching and they have a young person in their lives, and it may be something like anxiety, depression, or the full spectrum. What is out there now that people can take advantage of for youth? And then we can talk about what's coming online.
Yeah, so there are some resources certainly available for young folks, and it kind of follows that same crisis continuum that I described earlier. So there's that 988 line, that's for all ages. So if you're a young person out there who needs to talk to some sort of support, call 988. And then there's also that Teen Link line that gets patched through 988, our local center here. And they can get even that sort of more specialized support from a fellow teen who might have lived through something similar. Again, getting to connect in that way. There's a dedicated mobile response program for youth. That's called our Children's Crisis Outreach and Response System, CORES is what we call it, operated by the YMCA. And so you can call 988, and if you need that in-person response, again, CORES can come and see you in the community. They can offer some of that post-crisis
And they
follow-up
come to
too.
go to their house,
They'll go to their
assess the
house.
situation, talk to the
Absolutely.
young person,
Absolutely.
and come up with a plan.
Yep.
Which is pretty extra. You
You
know,
got
so much, you're doing this great work. And yes, we don't have enough. We don't have enough in place for sure. But I do think there is an education piece in people learning about what's available, this whole resource gap.
Yeah.
Yeah, that seems like a huge
I
piece
think
of
that
this.
a lot of the community too has the expectation that I can go to the hospital and you will
Yes.
get them there. You're going to take care of it. And that's what we see all the time. And so my staff as social workers, we have to be the bearer of bad news. And we have a lot of times and be very realistic with people about what can happen and what can't. And that's a really tough pill to swallow, especially for youth. It is a severe crisis in our hospitals at this time because we do not have enough acute care for youth. And so we are essentially keeping children in the hospital for very long periods of time, trying to figure out what in the world we can do. But they don't belong on a medical unit. So this is a hot topic for me in this current moment. So
Yeah, so
but,
basically
yeah.
you've got a number of youth coming into the emergency rooms because we know they're in crisis,
Yeah.
and you don't have enough
There's-
beds in the area.
Enough of anything.
Enough of anything.
Yes.
So where does this start? I mean, obviously the crisis care centers will be when we have the one for youth, but that could be down the road a bit, right?
There is also a new psychiatric urgent care that Seattle Children's Hospital opened up just a few months ago. And so they're seeing young people in that urgent care setting where their goal is to be able to serve youth in not the emergency room. You know, Seattle Children's gets a lot of young people coming into their ER, but they certainly want to be able to support people in that urgent care as much as possible.
And
too.
Mary Bridge, I think, and Tacoma has
Yes.
one, right?
Yes.
Has what, but again, probably not enough for the need that is there.
No.
Is that where you come in and the rest of it?
Yeah,
I mean, there's
right.
there's funding, there are funding pieces, and probably I would imagine is providers an issue as well, having enough providers.
Yes.
Well, I'm so glad you actually mentioned that. That was a point. The levy also provides investments around our behavioral health workforce.
Okay.
And so that's something that I think is really exciting. Oftentimes we hear that there's simply not enough behavioral health staff that work in this environment. And so the levy does make dollars available to do three things. We are trying to build up behavioral health pipeline. So working with community colleges, other sorts of places. Then we're also looking to retain our existing behavioral health workforce so that we don't lose them, because, you know, how many times have we experienced burnout, or I should say I've experienced burnout as a clinician myself. And it's easier to go work somewhere where I don't necessarily have to interface with people and I can make probably more. And then we're also looking to increase representation of our workforce so that we have a workforce reflective of the community that it's serving.
Yeah.
And another piece I think that's also really important is the concept of apprenticeships. There are behavioral health apprenticeships. And so oftentimes we think about individuals going through the traditional school path. An apprenticeship or behavioral health apprenticeships make it so that folks can enter into the behavioral health workforce in a non-traditional way, but still get that exposure and get the ability to work in this profession.
I did not know the levy did that, and that's pretty awesome. Yeah, so the part about retention, would that be like boosting salaries? Like
It's all of that. It is health and wellness. It is because we know oftentimes we give sick days and we give vacation days, but then people feel as if they can't take those sick days and vacation days. Or we say, hey, you're going to see all these clients, but then there's no downtime or self-care for them. Or we say, we need more staff, but in order to have staff, you have to have supervisors. And so this provides dollars to support supervision trainings as well as just other sorts of like clinical trainings that folks can have. So it's a whole gamut of what do agencies need in order to make sure that their staff are seen, heard, and understood.
I love that. And so the vision, though, is for just the vision is for us to have that dedicated crisis center for youth down the road. Okay, I really love that. Is there anything else you want people to know before we wrap up for today? I can start with you, Representative Macri.
I mean, just thank you, Angela, for covering this. I mean, I even learned some details that I wasn't aware of, and I've been in many, many meetings and conversations about this. I think this is, for me, every time I participate in a conversation, it's really exciting. I mean, I think this is, these crisis care centers are going to provide assets to our communities that we can't even really imagine because we haven't had access to them. I think about two things. One is I think about all those times when I've had a health issue and I was like, you know what? I really don't need to go to the emergency room. I know I won't be able to get a doctor's appointment for 3 weeks, but I need to take care of this now. And we just have not had anything for mental health that people can access care right away. So it's super exciting. And then I think about all the worst days of my life and like what I needed, you know, like when a family member has died, lost a job, relationship has broken up, like you feel incapable, right? And you might have resources, your best friend maybe can come over, and you think about all the things that your support network is able to do for you. Like sometimes you literally can't feed yourself when you're in such a state of despair. You forget to take a shower. You don't know if you should be awake or should just sleep for days. And I have seen these crisis care centers and how they work. There's all this great skilled evidence-based behavioral health, but there also is just this humanity about it, about caring for our neighbors when folks are struggling. And to me, that's exciting. I live on Capitol Hill, and so I'm excited that we have the opportunity for a place that is built for healthcare that we could transform for this particular kind of healthcare. So I'm just super excited.
Awesome. Thanks for sharing that. And you triggered one additional question I know we must address before the show ends, and then we'll get to our other final thoughts. And that question is, if we do see a loved one that could use some help, maybe it's not at ultimate, but can you force someone to go to the clinic? That's the question. What are the legal, if you feel like, listen, my relative is kind of at the breaking point and they need help, who can speak to the legality of when you need to intervene?
That is a very
I know, right?
question.
He has a lot today.
Yeah, there's a lot to say about that. You know, so there are ways for family members to try to engage their family in care. There's some specific laws that make that possible. For young people, there's something called family-initiated treatment. For adults, there's something called Joel's Law. And so there are pathways where a family member can kind of force one of their family members to engage in treatment. But again, I think Jennifer said it so well earlier. Part of what the whole crisis care center model is about prevention. It's meant to lower that bar and intervene much earlier in what's happening than waiting for that like full boiling over crisis moment.
Yes.
And so I would hope that by having these kind of crisis facilities open up, we're relying much less on involuntary treatment just in general. These are really meant to be specialty settings where you can engage somebody much earlier in their course of care. And voluntary care is better care. Like if somebody can be engaged voluntarily, it's their own motivation that's bringing them to the work. You know, this is about changing people's lives. This is not easy stuff we're talking about here. And so to really get into it, it's just so much more effective when somebody can be engaged voluntarily. And so my hope is that there's going to be a lot more of that kind of care available in the county.
All right. Wonderful response for a really tough question. Jennifer, any final thoughts?
I want to just highlight the importance that the Crisis Care Center levy was voter approved. So this was something that community said that they see the need and that they want to have within community. And so to that point, we as the county, we will not be operating these centers. We will actually be procuring those out to other behavioral health organizations. However, we still have an obligation to say, are we doing what we say that we're supposed to be doing? And so I think that really just amplifies the importance of community voice. And so a lot of the work early on in the planning, as like Nicole was describing in terms of the thoughtfulness, there was community engagement there. And while I think we did a great job, we didn't do enough. And there's always more that needs to be done. And so platforms such as this provides the opportunity, especially for groups and individuals who haven't historically had a voice at the table now have exposure to say, what is that? I want to learn more about that and how can I be connected? And then it is only through kind of that group process of I tell someone they have a good experience and then they go out and they tell their community. That's how the word gets out. We can sit up here and we can try to go door to door as much as possible. It's not going to have the same impact as if someone within like my circle or my loved one says, hey, this is a valuable resource. Yeah. So I think it's just the importance of community and community engagement. And while, like I said, we've done some, we've got to do more.
Yeah, great thing to highlight.
Yeah.
Matt, what about you? Anything else you want people to know?
Yeah, I mean, picking up on just what you said, we cannot do this alone. We need community to be deeply involved in this work. And so that means getting the word out about services. That means come work at a crisis care center. You know, there's a lot of jobs to be had here, and we want people from community to be working at these settings to really make it feel local and make it feel like people come, you know, and can be trusted. And then there's also a whole focus on accountability. You know, we are the county. We're responsible for using public funds, you know, as appropriately and ethically as we can. And we got to have our feet held to the fire. Like, we got to make sure that we're doing right by the folks who put that trust in us. We got to make sure that, you know, we're measuring outcomes, that we're bringing our findings and our outcomes back to community to hear from folks, you know, are we really doing right? Or what are the needs that are being met? What are the needs that are not being met? What do we need to change and improve? You know, this is going to be an ongoing thing for decades. We're not solving it all at once right now. And the only way to really make that work is by making sure that we're holding ourselves accountable. And I think that we've set up some ways to do that by engaging community, including over the long term, but there's a lot more to figure out here.
Love that. What about you, Amy?
So from an acute care in the hospital perspective, I just want to be sure to highlight how much of a pressure release this is for acute care settings. You mention this to anyone who works, physicians, nurses, anyone who works in an emergency department, and they are all for this because we cannot handle what we have currently. We simply cannot. And we want to be able to treat everyone in the best possible ways that we can, and we are not fortified with the services to be able to do that. It's very dissatisfying to our providers in the ER, to all the staff in the ER, to my own staff. Burnout is high, turnover is high, because you can only last for so long feeling like you're hitting your head against the wall over and over and over and over again. And that is the truth of what it is to work in acute care at this point in time. Physicians have told me, I didn't go into this to be a behavioral health provider.
Wow.
Like I
Because that's what it's feeling like.
Yes, because that's what they're dealing with. And my reaction is, well, you better learn, you know, you better figure out what's going on and take an interest in learning this then, because this is our reality. But just think about that feeling of coming to work for a lot of folks and not knowing they don't have the tools to service a large part of the folks that are coming to us. That's why my staff's there, but there's only so many of us too. And at the end of the day, we all want to help people. That's what we all want. And I think most of the community feels the exact same way. And, you know, perspective is so important. And, you know, we have that working with the folks that we work with. And not everybody does, but at the end of the day, I think it's safe to say that everyone wants what's best for others and wants to make sure people have access to the basic things they need and deserve.
Yeah. No, I can hear the weariness and the frustration and the hope, like all in one. So thank you for everything you're doing on the front lines, all of you. Amy, Matt, Jennifer, Representative Macri. Yeah, appreciate the work you do and for joining us to have this conversation. And I would be remiss if I didn't say that if you or someone you know is experiencing a mental health crisis, as we learned during this panel discussion, help is available in King County 24 hours a day, 7 days a week, just 988. That's my big takeaway from this, like 988 can get you started on the path towards getting help. And if you want to learn more about this new crisis care system, the new centers, there's a place you can go for that. Visit kingcounty.gov/crisis. That's kingcounty.gov/crisis. And if you do the Instagram thing, King County DCHS. So that's King County DCHS. Thank you all again for joining me. Thank you for watching. Take care.